Okay, so we will go ahead and get started. So thank you again, guys, for joining us today. We're going to talk all about delegation and assignment making and what you need to know about those topics in order to be successful on NCLEX. So before I get started, I'm going to briefly introduce myself. I'm Dr. Amber Adams. I'm one of the nurse educators here at Bootcamp, and I've been a nurse for about 15 years. Time flies. I can't believe it's been that long. And I have a lot of experience in emergency nursing. And then over the past couple years, I've primarily done nursing education. And I want to go ahead and introduce Miss Miriam. She's a nursing faculty member that's going to be in the chat today. She's going to be answering any questions that you guys have. And once again, there is typically a little bit of a delay in the chat, so please be patient with us and we will certainly answer your questions. So throughout this presentation, we're going to talk about just the appropriate principles of delegation and assignment making. Basically, what we need to be thinking about as we navigate this type of question. We're going to talk about what the nurse's role in delegation is, especially as it pertains to safety and accountability. And then we're also going to talk about some resources that we need to be using every time we participate in delegation. So the reason that we do a webinar on delegation and assignment making is because it is guaranteed on the NCLEX. So the NCSBN, they release a test plan and they're very transparent about what's on it. And we can see right here that management of care items account for about 20% of the exam that you're going to be taking. That includes prioritization, delegation, and assignment making. So once again, I guarantee you're going to see some delegation questions on the NCLEX. Now, I want to remind everybody before we get started that delegation is not just asking somebody to perform a task for us. It is a very complex nursing skill that comes with a lot of safety risk, okay? So we want to make sure that we are always following appropriate principles of delegation to keep our license safe and our clients. And then there are two general rules that just we must remember about delegation that I want to go ahead and put out there right at the beginning. The first one is we don't ever delegate tasks that require clinical judgment. That's nursing processed tasks or tape tasks, the teaching, the assessment, the planning, and the evaluation of care, okay? And we are only going to delegate routine tasks for stable clients. So never delegate a task on a client that is unstable or a task that's not routine. So if you remember those two things, we're already off to a very good start. Now, there are some resources that I want you guys to be familiar with and be thinking about whenever you look at delegation questions. The first is the scopes of practice. The scopes of practice is what can the RN do, the UAP, and the LPN or LVN. Now, before anybody gets too worried, every webinar, students typically will ask about very specific, nuanced things such as, what about an LVN that can give IV medications? Well, I want to go ahead and let you guys know, so I can alleviate some of your fear, that the NCLEX is going to be testing you on general principles of delegation. So if there is something that is legal in one state and not another, don't worry, you're not going to see it on the NCLEX, okay? And then also we need to be familiar with the 5 rights of delegation. Some questions we need to be asking ourselves as we start the process of determining, should I delegate this task and should I delegate it to this person? So let's take a closer look at these resources, and then we're going to jump into some practice questions because I know that is what you guys came for today. So first off, provider scopes of practice. So once again, typically on a unit, you're going to have multiple roles. You're typically going to have the RN, the LPN or LVN, which is the same person. It's just depending on where you live, what you call them, and then a UAP or an unlicensed assistive personnel. So let's briefly remind everybody about each person's scope of practice. So we'll start with the RN because we have the largest scope of practice. We are responsible for everything and accountable for everything. So we are able to care for stable or unstable clients on a unit. And we are responsible for performing all the steps of the nursing process. So that includes the teaching, the assessment, the planning, and the evaluation. And I want to remind everybody that the RN is the only one who can perform it initially. So initial teaching, initial assessment, initial planning, and initial evaluation, all that is RN's responsibility. And then we are responsible for performing routine tasks and non-routine tasks that are more invasive, such as hemodynamic monitoring. And when it comes to medications, the RN can administer all types of medications, and we are the only ones that are allowed to administer blood transfusions. So now let's look at LPNs. They can only care for stable clients. And although they can assist with the nursing process, they can only repeat those tape tasks. So they can come back and reinforce teaching that the RN performed. They can monitor the RN's assessment findings, and they can assist the RN with care planning. But once again, it's the RN's responsibility, and the LPN can just follow up once the RN completes the initial task. And they are only allowed to perform routine tasks. This is typically blood draws, collecting specimens, basic wound care, and they can give medications, but once again, the scope of practice on medications LPN can give varies greatly, but they typically can give oral medications, sub-Q medications, and routine IA medications. So I want to go ahead and say to you guys, if you've been in the clinical setting with LVNs or LPNs, you might not see this in practice. I actually was an LVN before I was an RN, and oftentimes was asked to do things outside of my scope of practice. So I know it can be confusing, especially if you've seen something different in the clinical setting, but this is what the NCLEX is using. So then lastly, UAPs. So they have the smallest scope of practice as unlicensed assistive personnel. They can only care for stable clients. They can never perform those tape tasks or those clinical judgment tasks. And they can only do routine and non-invasive tasks, such as measuring vital signs, ambulating clients, and they cannot give any medications. That is outside their scope of practice. So I know that was a lot, but that's super important. That way, whenever we are sitting down and we're taking a test and we see a delegation item pop up, we're not just guessing. We have a very good understanding of each person's scope. And then the last thing I want to briefly show you guys is the 5 rights of delegation. These are essentially 5 questions we need to be asking ourselves whenever we perform delegation. The first is the delegatee, or the person being asked to perform the task, competent? Is this something that they should have information on, that they should know how to do safely? Then we have to ask, is that task routine and within the delegatee's scope of practice? And then circumstance is very important. We need to determine, is the client stable, and am I also available to supervise? Because I want to take this moment to remind you guys that as the RN, we can't just say, hey, can you please go do this? And then we leave the unit for an hour. The RN is accountable and responsible for the outcome of the task. So we need to be around to supervise and make sure that task was performed correctly and be readily available to answer questions. And then communication is key. We need to be as clear and explicit as possible. So for example, instead of saying, hey, can you go do vital signs on the client in room 5 today? No, we need vital signs on the client in room 5 right now, please, and let me know if their blood pressure, systolic blood pressure, is greater than 120. We have to be as clear as possible. And then lastly, we always must follow up. We must determine, did the client tolerate the task well? Did everything go as planned? And give feedback to that delegatee. So somebody asked about tape task, and thank you, Cassie. It is, once again, those nursing process tasks that require clinical judgment, including teaching, assessment, planning, and evaluation. Those are things that RN is responsible for. So I know, like I said, I just gave y'all a lot of information, but really, if y'all are familiar with those resources, you're going to be able to navigate any delegation item from a very strategic approach and be successful. So don't get mad at me, but the first question out of the gate, I thought I would challenge y'all a little bit. So I know everyone loves select all that applies, especially ones with 8 options. But this is a helpful NCLEX tip. Don't be overwhelmed when you see SATAs, especially ones with this much stuff. Remember, just take it line by line and treat each option as true or false. So let's take a look. The nurse is planning care for several clients on a medical surgical unit. Which of the following tasks should the nurse delegate to the UAP or unlicensed assistive personnel? Okay, so option 1, foot and nail care for a client with diabetes. What do we think? Are we going to delegate this? Yes or no, or true or false? Well, typically when we see foot or nail care, we would think of that as a routine task. But when we look at the circumstance, a client with diabetes, do we still think that that is routine? No. I see Cassie said no, King family, no, Maria. Okay, I agree with you guys, and let's talk about why. So remember, clients with diabetes typically have two issues affecting the lower extremities. The first one is issues of circulation or poor perfusion, and then peripheral neuropathy, where they experience numbness, weakness, decreased sensation. So we know they are at very high risk for foot infections and delayed healing to the feet and lower extremities. So the nurse should be the one responsible for foot and nail care, and sometimes we even refer them to podiatry because they are very high risk for, once again, injury, infection, and sometimes if the neuropathy and the poor perfusion is so bad, that can actually lead to amputations for these clients. So it can be a very high-risk task. So I agree with you guys. I'm not going to delegate that. So now let's look at number 2. Assist a client experiencing confusion to the restroom. What do we think about option 2? So assisting somebody to the restroom would be a routine task, and we see they are experiencing confusion. And this is where I would get in trouble as a nursing student. I would see that and I would just go down a rabbit hole. I would think, oh, maybe they're having a stroke. No, guys. Okay, let's just take the option for face value. Let's not add information. There's nothing that says it's new. It seems like this client is stable. So I agree with you guys. I am going to delegate option 2. So option 3, replace the old IV tubing for a client receiving antibiotics. What do we think about that one? I think that one's a little bit easier, huh? So we know that we must change the IV tubing typically every couple of days because we don't want the client to develop infections or complications related to that. But we know if we look at that UAP scope of practice that they cannot administer any medications. And that task requires a lot of clinical judgment. Remember in nursing school how scared you were probably the first time you were trying to prime tubing? We don't want to give clients air embolisms, and we know that, once again, it has a lot of clinical judgment behind that task. I think we can not delegate that. Then option 4, ask a client who recently received analgesics to rate her pain. What do we think about that? So typically, when we ask somebody to rate their pain, that can be part of the vital signs, and that could be a routine task, but once again, we have to look at the circumstances. And this client just received analgesics. So if a client just received pain medication and we're coming back to follow up and assess their pain, we are evaluating care and actually performing a client assessment. So we do not want to delegate that. Y'all are doing phenomenal. Yes, Meg, that's assessment. Very good. So option 5, denture care for a client who requires assistance to feed himself. What do we think? Denture care is just going to be a routine task, oral care. And once again, this is where you could get yourself in trouble and say, oh, well, if they need assistance to feed themselves, maybe they're at risk for swallowing issues. Don't do that. It doesn't say anything about that. They seem stable. So I agree with you guys. We can delegate that. And option 6, assist a client with rheumatoid arthritis and contractures onto the bedpan. Once again, routine task, stable client. I agree with all you guys. And then perform a partial bed bath for a client post-operative day 2 after a hysterectomy. Once again, partial bed bath is a routine task, and this client is 2 days out from surgery, so they should be stable. And then lastly, help a client with peripheral vascular disease put on elastic compression stockings. What do we think about option 8? Do we like option 8? So we know with peripheral vascular disease, you typically have blood pooling, and we need compression stockings to help improve the blood flow back to the heart. So compression stockings are a very, very important intervention. So for these clients, we could let the UAP put on the stockings, but remember, as the nurse, we must come back and evaluate were they put on correctly. Yvonne, you said don't overthink, and I agree with you. And I will tell you, delegation, I find, is one of the topics that people overthink the most on. So very good advice. Okay, so we got them all correct. So awesome job, guys. So I made the next one a little bit easier. I didn't want to just overwhelm you guys with SATAs with tons of options. So this next question is also a delegation question, but it's formatted differently. So a lot of the delegation items you will see are formatted to just say which task is appropriate for delegation. But we've also seen that NCLEX uses this type of formatting, which is a little bit different, and I think it's a little easier to get confused on. So let's look at the stem, the question, really carefully. It says the charge nurse is supervising an RN in the care of a client with hypertension. The charge nurse should intervene if the RN asks the UAP to do what? So basically, this stem is asking us to identify inappropriate delegation or an unsafe delegation request. And I know y'all are already guessing the answer, so let's see if y'all are right. So option 1, document the client's blood pressure and heart rate every 8 hours. So if we are asking a client or asking a UAP to document blood pressure every 8 hours, that is a routine task, and it appears that this client is stable. There's nothing to indicate this client is unstable. So I think that that would be safe to delegate. And remember, we're looking for something that is unsafe to delegate. Option 2, report a systolic blood pressure level below or above specific pressure. So that's basically saying, hey, can you please go check this blood pressure and let me know if the systolic blood pressure is greater than 130 or less than 100. It's giving very specific parameters. I think this is appropriate, and if I was that charge nurse, I would be like, kudos to you, RN. You just did an amazing job communicating. So I think that that is very appropriate. So all of you guys are wanting option 3. And Mighty Mike, you said it's because it's teaching, and I agree. So once again, carvedilol, showing the client the correct way to measure a pulse before taking carvedilol. We know carvedilol is what kind of medication? That LOL at the end should give it away. It's a beta blocker. And we know that even though it's given for high blood pressure to reduce the blood pressure, what other vital sign is it going to affect? Besides blood pressure, what else is it going to affect? Heart rate. So remember, if we always, NCLEX tip, you know, with beta blockers, we're always checking the pulse before we give a beta blocker, because if their heart rate is low and we give it, we can cause life-threatening bradycardia. So can anybody tell me, as a bonus question, what heart rate would make me want to hold a beta blocker? So if I was assessing a client and I saw this heart rate, which one would make me say, oh, I'm not giving this medicine? What's usually the cutoff? Anyone tell me, what heart rate should I be concerned about when given a beta blocker? And once again, my chat is delayed, so y'all can see each other's comments before I can. So the answer is 60. Very good, Cassie. So if you see a heart rate of 60 or less, we are holding that medication. So we always need to teach our client that as well. We need to teach them when they get home how to check that pulse and to hold the medicine if the heart rate's less than 60. So far, I think 3 is going to be inappropriate delegation because it's client teaching. But let's look at option 4, because I saw a couple people did choose it. So option 4 is measure orthostatic vital signs supine, 3 minutes after sitting and 3 minutes after standing. So just to refresh everyone's memory, orthostatic vital signs is assessing a client's blood pressure and heart rate when they're lying down, after they've sat up for a couple minutes, and after they've stood for a couple minutes. And what we're doing is we're looking for big fluctuations in the blood pressure and the heart rate that could indicate fluid volume imbalances like dehydration or other issues. This would be appropriate to delegate to that UAP as long as they understand how to do it. And we gave them very specific instructions saying, check it when they're lying down, 3 minutes after sitting, and 3 minutes after standing. So I think that that would be appropriate. And I agree with you guys that option 3 is best. Okay, so now that we've looked at 2 different ways that you might see delegation topics formatted on NCLEX, let's shift gears entirely. We don't talk about assignment making as much, but you still may see assignment making on NCLEX. Now, these can be formatted many different ways as well. Sometimes we might be asked to assign a nurse to a specific client or assign a nurse to a specific unit, and sometimes we're asked to assign a client to a specific unit to make sure they have the care they need, because that is a huge safety issue. So this one is going to be us assigning a client to an appropriate unit. So it says the medical surgical nurse is caring for the following clients. The nurse should recommend a transfer to the ICU for which client? Okay, so let's talk about this very briefly. On the medical surgical unit, this is typically stable clients, and we are looking to determine who do we need to send to the ICU. And ICU, once again, is the critical care setting where it is the sickest of the sick, okay? So option 1, pneumonia and requires frequent administration of IV antibiotics. Option 2, a new colostomy with redness and excoriation at the colostomy site. Option 3, warmth and drainage at a skin graft site following a traumatic burn injury. And option 4, COPD with a pulse oximetry reading of 92%. And all of you guys are guessing one option, which is 3. So let's see if you're right. So option 1, pneumonia requiring frequent administration of IV antibiotics. This is a stable client and we should be able to safely administer IV antibiotics on a med-surg unit. Now, let me give you an example of when we would transfer this client. Maybe they are experiencing dyspnea, or they are experiencing tachycardia, or they have an elevated lactate level. So what did I just describe? What clinical condition did I just describe? If I have a client with pneumonia who is tachycardic, has difficulty breathing, and now has a positive lactate level or an elevated lactate level, what are we thinking about? Because I know y'all all have probably guessed the right answer, but I want y'all to get some more learning from the wrong answers. So that's a pop quiz. Pneumonia, positive lactate, dyspnea, and tachycardia. What am I worried about for my client? It's going to be sepsis. Yes, very good job, Valerie. Yes, wonderful, guys. So in that case, I am shipping them to the ICU. So I can do hemodynamic monitoring. I can try to keep them alive, right? Option 2, a new colostomy with redness and excoriation at the colostomy site. So this client is a brand new colostomy, so we know that that comes with a lot of issues related to comfort, potential for infection, and this client's experiencing redness and excoriation. It could be just normal irritation, but also could be sign of an infection. Now, at this time, there's nothing to indicate they're hemodynamically unstable. There's nothing that says they're experiencing tachycardia, fever, anything like that. So I believe they are also safe to remain on the med-surg unit. Then option 3, warmth and drainage at a skin graft site following a burn injury. Okay, so remember, we send people to ICU if they're hemodynamically unstable or if they require specialized care. So clients with a skin graft typically require specialized care because it's a very high-risk procedure. There is a high likelihood of rejection, and typically they need specialized burn care. So I agree with all you guys that so far 3 is looking like the best option, but let's check out 4. Option 4, COPD with a pulse oximetry reading of 92%. So why am I not concerned about that? Because 92% is outside of the normal range. So we anticipate a client with COPD to have a decreased pulse oximetry reading. We know that damage to that lung tissue can affect oxygenation. So that's actually an expected finding for this client. Now, if I gave you the example of a pneumonia client with the pulse oximetry reading that low, that would be different. But for this client, it is expected, it is chronic. I think we will ship that one to ICU, and we got that correct. Okay, guys. I'm so impressed with all of y'all's answers, for real. Y'all are doing phenomenal. Yes, hypoxic drive. Yep, the chronic condition. Very good. So that's it for the questions, but I want to give you guys a chance to ask some questions. So I want to go ahead while y'all are typing in the chat, share with y'all our cheat sheet. So if y'all have not already heard, we have been working very hard here on developing some amazing cheat sheets, and we've had some wonderful student feedback that these cheat sheets have really helped them. So we do have one on delegation and assignment making, and it does cover some of the stuff we reviewed today, and then it also provides you with some additional information, resources, and practice questions. So if you haven't been checking out our cheat sheets, please do, because they are awesome. Also, please follow us on our socials if you haven't already, and certainly check us out at bootcamp.com, where you will find all kinds of stuff to help you prep for NCLEX. Any questions here? Miss Miriam did put all of our links in the chat, so please feel free to click on those. So Esther, we do have some study schedules available. I know that's, can be very discouraging, but you've got this. We have study schedules, and you just put in when you plan on taking it again, and it will actually help guide you. It's very interactive. It has a very detailed study plan to help you get started. Those cheat sheets are a lifesaver. Thank you. We've worked so hard on them. We think so too. We love them. Okay. And then Esther, Miss Miriam just shared the study calendar for you. Okay, guys, well, thank you so much for joining me today. I hope this helped you guys, especially those of you taking NCLEX this week. Hopefully when you see a delegation item pop up, you're gonna breeze right through it. Okay, well, y'all have a wonderful rest of your day.